This presentation will look at the components and instrumentation used to manage soft tissue healing and to take transfer impressions with the Ankorlock implant system. In particular, we will be looking at tissue expanders, transfer bases, instrumentation such as the universal hex tool and extender, and finally a laboratory component, the universal analogue. When it comes to healing abutments, we provide two options in the system: tissue expanders and transfer bases. This presentation will look at the use of both of these types of healing abutment. However, we will not be discussing the technical applications or how they are used in the management of soft tissue. This information is contained in other presentations delivered during our training courses, which are more specifically aimed at our users and those people attending our blended learning implant training programs. Well, first let's look at tissue expanders. Now we have three lengths, and it's important to realize that all three lengths fit all diameters of implants. The selection and choice of length will be covered in our blended learning and training programs. However, it's important to realize that these healing abutments are not only guiding the tissue, but they can also be used in protocols to boost the soft tissue and develop the biotype of the soft tissue as well. But these are all techniques, clinical techniques, which are discussed in our training programs. Now, it's also important to realize that whilst they fit all diameters of implants, they cannot be used to take a transfer impression. They work in conjunction with our universal hex tool. Now, our tissue expanders are positioned using the universal hex tool. Now, again, it's important to realize that the universal hex tool works not just with our expanders, it also is used to position the cover screw on the implant, and also it works with all our prosthetic screws as well. So the one instrument, the universal hex tool, has three functions. It positions tissue expanders, which are a range of our healing abutments. It is used to position our cover screws, and it is also used to insert all our prosthetic components and post screws. So this is a very versatile instrument. It cuts down on the amount of inventory that you will need to carry. It's easier for your nurses to maintain and store. So it's a very useful tool, and it's a very complex tool to manufacture. Before using the universal extender or driver, you must make sure that the little O-ring, the little black O-ring here, is in position. This helps to retain the universal hex tool in the driver or in the instruments that you might be using it with, and if this is either worn or lost, then obviously the tool will not be securely held in the instrumentation and could be dropped into the patient's mouth and inadvertently inhaled or swallowed, causing an emergency visit to A&E. Now, the next range of healing abutments that the system has is our transfer bases. Now we have two lengths, and one diameter fits all diameters of implant, and they can be used, unlike the tissue expanders, they can be used in order to take a transfer impression, and they are used in conjunction with our extender, and this extender has again multiple purposes. It is used to place all our implants, so this one extender works with all implant diameters. It also works with the transfer bases. So this extender has two uses and is in the keeping of the philosophy of our system, which is we try to get the instrumentation to carry out as many functions as possible in order to reduce the number of instruments you need and to make inventory far easier to keep track of. Some of you may have realized that our healing components are not made from titanium as with other systems. Instead, it is made from a radiopaque Peek material. Now, this is a special medical grade plastic. It's used in engineering, it's used in orthopedics, and it's also used in actual implants as well. So it's a very expensive material, but it's a very biocompatible material as well. And we use it extensively on our system. We're perhaps unique in using a range of peak healing abutments. And again, this allows us to modify these abutments in more advanced techniques where we're trying to grow or expand our tissues. But on a day-to-day use, the main advantage of these kinds of components is that if they hide the occlusion or prevent a prosthesis such as a denture from being fitted, it's a very easy matter to drill these components down and adapt them so that a denture can fit over the top. Now, this would be very difficult with a titanium component and would often necessitate that the dentist starts to cut away at the patient's prosthesis, which is not only alarming for the patient but also weakens the prosthesis and can predispose to its later fracture and more inconvenience and clinical time. So these abutments are very easy to use. They're pushed into position and then they're left and the soft tissue heals around them. They are not used in conjunction with any screw. As you can see here, there is no screw hole at all. The component is just pushed into the top of the implant, and this eliminates all micro leakage because there is no micro gap. And we will see that the bone here is growing over the top of our implant because there is a lack of micro leakage. So these components are very useful not only for transfer impressions and for soft tissue healing purposes, but they also eliminate the micro gap and help preserve our crestal bone. Now, for those amongst you who are interested in sizes and dimensions, this diagram shows the height, and although the diameter of the transfer base can vary slightly, this plays no role in the actual fitting to our implants, and all these bases will fit on all diameters of implants. Now, this cutaway diagram shows the absence of a post screw hole because this is a screwless healing system, and it's been designed that way to actually try to preserve our soft tissues as much as possible and make the system much easier to use by cutting down on the number of components and screws required in order to proceed to final restoration. We're now going to be considering our Ankorlock transfer impression system, and in particular we're going to be looking at the Ankorlock quick transfer and our transfer bases. Now, the quick transfer is made from Peek, and this means that it can be cut down to reduce the height to enable the tray to be fully positioned, and also where our implants are at all angled, or there may be convergence or confliction of angles, these components can be bent again to accommodate positioning of the impression tray during our transfer procedure. Okay, so the Ankorlock system permits two types of transfer impression. One is at the tissue level and the other is at the bone level. The indications for when you would use either or will be covered in our specific lectures given in our blended learning program and our clinical training programs. So we have two types of impression, one being a transfer base impression, which is taken directly off the soft tissue healing abutment, or a fixture head transfer impression, which is taken directly off the top of the implant at bone level. So the difference between these two is the presence of our transfer base. Now in this cross-sectional diagram we can see the two lengths of transfer base in position. We have the long and the shorter transfer base, as you can see, but the interesting point is that regardless of how long our transfer base is or what transfer base you have used for the transfer impression, as long as the technician uses a transfer base, it does not matter which length, because the system has been designed to always give the correct vertical positioning of our implant regardless of what transfer base has been used. So if the technician wants to use a shorter transfer base because it helps in the production of the analog model, he can do without worrying that the position of the analog in the model will not relate to the position of the implant's vertical dimension within the patient, because as I say, the transfer bases have been designed to accommodate this vertical discrepancy. So this clinical picture shows a transfer base in position. The case was an immediate placement which was placed a week earlier. The lateral incisor was extracted and an immediate implant inserted, and then a transfer base placed on top. This was allowed to heal for a week to let the soft tissues settle, and it's interesting also to note that the soft tissue margin, if you like, is not too far off that of the corresponding incisor tooth, because this technique is used to try and preserve soft tissue profile after immediate placement. So now we are ready to do our transfer impression from the base, or a tissue level impression. Now the transfer is pushed securely into position on top of the transfer base. The impression material is then injected through the top of the quick transfer and escapes out through the side vents. This allows the quick transfer to be securely locked within the impression material. Now for this procedure we recommend a material called monoprint transfer. If you haven't got this material, then I would suggest that you use something like Improgum Hard or Improgum Original, and this will work equally as well, but it's important to appreciate that the impression material must set hard and be rigid for the transfer to be accurate. You should not use impression putty or any wash type silicones or light body silicones, because they will either displace the transfer altogether or they will not have sufficient strength to retain the quick transfer in the impression when it's withdrawn, or the material may even rip and the transfer be displaced altogether. Should that happen, it will be necessary to retake the entire impression. You cannot accurately reposition the quick transfer into an impression if it's been displaced. So in this situation you must clean the quick transfer, remove the impression material from the vents, reposition and take the impression again. Now, unlike Improgum, monoprint transfer comes in a cartridge system, and this makes it very easy and quick to use in the surgery. However, as I've said, you may use Improgum hard. This is just mixed and used in the same way as usual in conjunction with a syringe in order to inject the material through our quick transfer. When the impression is removed, you can see that the Ankorlock quick transfer has been trapped within the impression material. Now we can tell that this has been taken off a transfer base or at soft tissue level, because you will notice that there is a recording of the top of the transfer base. So this helps technicians to just confirm how the impression was taken before going on to produce the definitive analog model. The technician will now use our Ankorlock Universal Analogue. This analog works with all diameters and dimensions of our implants. So again, this makes inventory very simple and very simple to track the process of the job. And also for laboratories, they only need to order the one analog. Many systems which have multiple diameters with multiple hex sizes require that you use the corresponding analog to match the implant being used. The Ankorlock system does not do that because we rely on a universal hex and a universal connection system and screws to keep everything as simple and as easy to manage as possible. So just to recap on our transfer base impression, we position the quick transfer into the top of the transfer base, as is seen on the left hand side. Impression material should then be injected down through the quick transfer so that it escapes through the side vents. This will help lock the component into our impression. The impression is then removed, leaving the quick transfer base in position on the implant and taking the quick transfer with it locked in the impression material, like so. As I've said, this is most important that you use the correct impression material, and that if there is any doubt about what has happened or the accuracy of the impression, then it should of course be retaken. Now at the laboratory, the technician uses the universal analog, but he must place a transfer base on the implant. Now, as I've said before, it doesn't matter if he doesn't use the same length of transfer base because the system is designed to accommodate this kind of discrepancy. The main thing the technician must remember is to use a base. If a base was used in the original impression, then a base has to be placed on top of our implant analog in order to produce an accurate analog model. If the base is not positioned, then the implant or analog will end up being too high within the model, and the final restoration will not fit and be high to the occlusion. Now, unlike the transfer base impression, the fixture head transfer impression occurs at bone level. And here there is no intervening transfer base. There may be a healing abutment in place, that could be a tissue expander or a transfer base, and this is removed and the quick transfer is positioned directly and locks directly into the implant hex. This may be a situation where there is limited height, or as I said, it's not possible to transfer off a tissue expander. So if a tissue expander has been used to help develop the site at all, then this will need to be removed in order to accommodate the positioning of our transfer, our quick transfer onto the fixture head to allow us to take a bone level impression. And again, the impression material should be injected down through the quick transfer so that the venting ports allow impression material to pass through, locking the quick transfer securely in our impression. Once the impression has been taken, obviously the healing abutment can be reconnected. This picture shows an Ankorlock implant which has been inserted, and it is intended to take a bone level impression at the time of placement. The quick transfer can be positioned directly into the top of the implant, and in this situation Improgum hard is being used for our transfer impression. It is also worth noting that you can autoclave the Peek component prior to use if you're intending to use them in any surgical type procedures. Now back at the lab, following proper decontamination of your transfer impression, the technician now starts to produce an analog model. It's important again to realize that unlike a transfer base impression, in this type of fixture head impression we do not need to use the transfer base, so the technician does not need to consider the need for a transfer base, and the analog is pushed directly onto the quick transfer and the analog is produced. So we have, as I say, two options here, either a tissue level option or a fixture head option. When and the indications for these types of impression will be discussed in our blended learning and our clinical training programs. If you're interested in any of these, please contact OsteoTie, who will only be too happy to assist you.